Good morning. Welcome to this session. Last week, I introduced the endocrine system. We did a classification of the hormones into group 1 and group 2 based on the location of their receptors. We equally did a chemical classification of hormones into steroidals and non-steroidals. And the non-steroidal hormones included the amino acids, the polypeptides, and the amine groups. We further went ahead and looked at the regulation of the hormone effects in the body, where we looked at the negative control system and the positive control system. We give an example and we said all hormones uses a negative control system with an exception of oxytocin, as it's utilized during the process of parturition. We further went ahead and looked into the axes, and the highest axis or the highest gland was the hypothalamus. And just slightly below it, we do have the anterior pituitary gland, and below it, we have other glands that form the whole axis. We classified hormone into either being the anterior pituitary gland produce or the posterior. And we stated that the posterior pituitary gland only secrete two hormones, that is the oxytocin and antidiuretic hormone, and all other hormones are secreted in the anterior pituitary gland. Yeah, there's someone whom their audio device is on currently. If you know your audio device is creating some disturbance, you can put it off. I think that is Clinton Aondo. Yes. You can mute kindly. And on today's sessions, we'll continue the same journey and start at looking at a very specific hormones. And we'll start by looking at the gender differentiation hormones, and in particular, the female hormones. We classify them, there are simply two. We have the estrogen and progesterone. And the estrogen hormone is responsible for the following effect in the body. And it enhances the growth of the other cells in the body. We call them the somatic cells. And the differentiation of the somatic cells will lead into a physical growth as it happened during the puberty. So this is a literal increase in the body weight and the increase in height. And most of this effect we realize usually start at the puberty, as we later see when we do a review of the female reproductive system. The mammary gland growth or the growth of the breast also occur during the puberty and courtesy of estrogen hormone. And the sex organ or the reproductive organ will differentiate and increase in size also due to the effect of estrogen. Closely related to estrogen is another hormone called progesterone. And we later review that they are synthesized together from the same precursor, which is cholesterol. And progesterone is responsible also for the differentiation of the mammary tissue, specifically the ductal system of the breast or the mammary gland. So the uterine lining usually increases in thickness, and that is the courtesy of progesterone. And we have another organ called the corpus luteum, which upon the process of ovulation, the cells will be transformed into another organ called the corpus luteum. And the corpus luteum will usually continue to produce progesterone if pregnancy takes place until about a duration of 2 to 3 months before the placenta takes over. and we'll also look that one the details into when we review the female reproductive system, the cyclical changes. We have some prostaglandin, specifically prostaglandin F2 alpha, usually causes the regression of the corpus luteum. In that, if pregnancy doesn't take place, the corpus luteum is programmed to die a natural death of exactly 14 days between from the day ovulation take place. So unless it's get a rescue from a beta HCG, which you call the beta human chorionic gonadotropin hormone, which will be released from the syncytial trophoblast upon the process of fertilization, it will otherwise die. And we'll see the significance of that program cell death of the corpus luteum and the significance of the exact 14 days plus or minus 1 day and the impact it has on the face. We call it the luteal phase. That is usually a very fixed phase, unlike the phase, the follicular phase, which will also cause the difference in the menstrual phases. In that, in this class, for example, you can, if I randomly take all your menstrual phases and do a calculation, it will range between 26 days to, and some going to up to 35 days. And those that goes between 26 days or even sometimes 21 days to 35 days, there's one phase that is constant, and that is will be the luteal phase or the last phase. And that is the courtesy of this hormone. But the other one is variable, and the variability is what lead into the differences in the length of the menstrual cycles among different people. We proceed on. After looking at estrogen and progesterone, we look into another hormone called oxytocin. And we said oxytocin is among the two hormones secreted from the posterior pituitary gland. But we stated that it's actually being stored at the posterior pituitary gland, but the secretion and the synthesis actually occur at the hypothalamus. Oxytocin is responsible for the smooth muscle contraction. And during the process of giving birth or towards the last third trimester, the receptors at the uterus usually increases and become more sensitive to it. And during the onset of labor is marked by an increase in oxytocin, which will start causing a contraction in the smooth muscles of the uterus, thus pushing the baby down, and the process of birth takes place. Besides that one, it also causes the contraction of some cells lining the duct system in the breast, called the myoepithelial cells. And the contraction of these cells will squeeze the milk out, and the baby is able to breastfeed. It's for this reason, for example, if you ever observe a mother, when they hear the cry of a baby, and that one will cause the milk to literally be ejected breast without necessarily a baby suckling the nipple. The reason for this one is the release mechanism has both a physical part and also an emotional part, as we see later in the next diagram. So it also causes an increase in cervical dilatation, for example. But if you dilate the cervix, it causes an increase or the secretion of oxytocin. And this mechanism is utilized during the process of induction of labor. When a mother who is pregnant goes beyond 42 days, and the midwifery class will tell you that it will be postdatism, so that pregnancy has to be delivered. And one of the ways of initiating the process of labor, it can be done chemically or pharmacologically, or it can be attempted physically. So the physical modality is usually preferred in some setting. And the chemical modality is simply to give a prostaglandin, and the prostaglandin will cause the contraction of the muscles of the uterus. Chemically, mechanically, you can do a manual stimulation of uh, the cervix, and that can be physically by swapping it with a glove or simply causing a dilatation using a Foley catheter, and you dilate the catheter with normal saline, and that will create a pressure in the cervix. And the distension of the cervix will cause a release of the oxytocin from the posterior pituitary, thus causing the contraction of the uterus. That is how the chemical induction of labor occurs. And also, we say that the progestin or the progesterone usually inhibits the release of oxytocin. Before the delivery of the baby, it's almost impossible to cause the secretion of the milk from the breast. If whenever baby suckles the breast before a mother delivers, the milk cannot be secreted or released, because at that time we still have a very high level of circulation of the progesterone in the blood. But once we deliver the baby, which will be followed by the delivery of the placenta, the level of the progesterone will suddenly go down, because I stated that from the third month, the placenta usually takes over the role of producing progesterone. And if you remove the placenta at the third stage of labor, their level will suddenly go down at a few hours. And the inhibition it has on oxytocin will go down. And within a few hours, the baby will start to suckle and the milk will come out. You might also make an observation at the labor ward or the post-delivery ward, postnatal ward, that is, that some mothers will take some time of even up to 24 hours before starting having a milk let down, while some will take prolactin. And the prolactin has an effect of synthesizing milk protein. So their effect usually come very early, immediately within the 3 to 4 months. So it will start to increase the protein synthesis in the milk to ensure the synthesis and the production of milk. Also, beside that one, it causes the increase in the mammary gland in preparation for the milk secretion. And an increase in estrogen and a low protein prolactin inhibiting hormone causes its increase, as I stated initially in the first point. So then that prolactin causes the synthesis of milk, and it causes the growth of the mammary gland, but on its own, it doesn't cause the release of the milk, and that will be the function of oxytocin. But both functions are interdependent. So this is a diagram that I stated initially, that we have a nipple, that a physical stimulation of the nipples, as for example, when a baby suckles, will cause an impulse to be sent from the nipple into the spinal cord and all the way into the hypothalamus. So at the hypothalamus, it will cause a synthesis and release of oxytocin, which we said that one occurs at the hypothalamus, which will be released into the posterior pituitary gland. And from the posterior pituitary gland, it will be released into the circulation. So at the circulation, it will bind into its receptors, which are located in the mammary gland. And the contraction of myoepithelial cells will cause the release of the milk. Okay, so we proceed on and see at the gender development of hormone and the effect it has on the body. So we start at looking at the testosterone hormone, and it's predominantly available in males compared to females, but also in females, we have testosterone, but the level is usually on the very lower end or side. And testosterone on its own usually doesn't have an effect in the brain of the male, in that testosterone doesn't really give you the male features in the brain, but instead it has to be converted into estrogen so that it can causes the effect in the brain. And the conversion of testosterone to estrogen is caused by an enzyme called aromatase, and the estrogen will have the effect in the brain that's giving the male future. Okay, what will happen then that females have the highest level of circulating of estrogen and they don't have the masculine features. So females have another hormone called the alpha fetoprotein, and the alpha fetoprotein binds to estrogen. And once it binds, it prevents estrogen from entering the brain, and this will causes the female to lack the masculine effect in the brain. So testosterone hormone in males is responsible for certain features. We might not appreciate most of these features in human beings, but if you look at other primates and all other mammals, the male species, we might be able to appreciate them. So for example, features of male aggression, where we have the dominant male controlling the mating in animals that occurs in group. So for example, if you look at the group of lions, for example, at the pride of lions, you might be having or will always have one dominant male, and the dominant male have some features that it's very aggressive because it's the only one that has the mating right, and that one coincide with the rise in the level of testosterone. And that one comes with an aggression, that it causes an aggression in male, but we say that in human beings, that one is not so much self-evidence. So it also causes resistance in the urge to mate and the territoriality and jealousy. So I think this aspect of jealousy, we can appreciate it in males, for example, that if at the end of class, for example, you are coming from a lecture hall and you suddenly see, someone else, maybe a classmate, holding hands with your girlfriend, that will probably make you jealousy, and it's because of testosterone hormone. Because otherwise, if for some reasons you have removed your testicle in early stages and you are unable to have higher level of testosterone, you'll not probably be jealous if you see someone holding your girlfriend's hand, and maybe that is not your friend, but that one still remain to be hypothetical. So oxytocin in females, but we should also underscore that oxytocin can be released in both male and female, but it has more effect in females than in male. At what point do we secrete oxytocin at males? So the secretion usually occur immediately or during the process of sex. And during that process, immediately after copulation or after the sexual intercourse, oxytocin level will increase in circulation. And it will cause a release in some other hormones. We call them the opioids. These are the internal opioids, not the external one where people abuses. And the secretion of opioids will causes a reduction in aggression. But immediately, usually after sex, male tend to be very calm, less aggressive, and they become a little bit more laughing, and there is a chance they might sleep afterward, is because of the reduction in aggression, and that all the animals that have a nurturing behavior that take care of their offsprings, including human beings, usually have oxytocin. And for animals that don't have a nurturing behavior, for example, the reptiles, lack oxytocin, and for that reasons, they are unable to nurture their young ones. And also the social memories, the good memories that you probably remember from your childhood, is because of the syncing effect of oxytocin between you and your mother, probably. So the gonads include both the male and female organs for secretion of hormones, and the male gonads are the testes, and they are two in size. We'll look into the details of them while we look at the male reproductive system. It has two effects, a steroidogenic effect and a gametogenic effect. So meaning it produces both steroids or the sex male hormones, and it produces the gamete, in this case, the spermatozoa. The details of that one will come in male reproductive system. So steroidal hormones, we say they are androgen and estrogen, and androgens are the predominant one, and the predominant one are the testosterone, but you also have the estrogen in slightly lower amount. So in females, so the gonads include the ovaries, and we said it has both the steroidogenic effect and the gametogenic effect. So the effect is cyclic in nature, in that it happens in the cycle. We call it the menstrual cycle, which has two phases, and we look into the detail of that one when we review the female reproductive system. So, but the primary ovarian hormone, including the estrogen, progesterone, and testosterone. But we said that the testosterone is on the very lower level. So we said it has three phases, the menses, follicular, and the luteal, but we'll talk in detail in the next class. So then that's enough about the gonads and the hormone that it produces. We proceed on to see another axis called the hypothalamothyroid axis. So that is the axis between the hypothalamus and the thyroid gland. And the thyroid gland, when we reviewed, I think you must have reviewed already your regional anatomy, and you must have reviewed about the head and neck. And we're reviewing at the head and neck, we have the thyroid gland located just slightly below the cricothyroid cartilage in the anterior side of the neck. And I think you appreciated that it has two lobes, the left and the right lobe, with some stalk connecting them in between. And in an adult like you and I, if you touch just slightly below your thyroid gland, slightly below your cricoid cartilage, which is not so much self-evident in females, but upon palpation, you'll still be able to appreciate it, that you will not be able to palpate your thyroid gland because normally it's very small in size. But in some pathological condition, in a condition called goiter, so the gland becomes so much massive in size that it sometimes causes obstruction, which we'll have to remove surgically. And the way to really assess it is to tell someone to swallow saliva, and you see the rising and the falling of the thyroid if it was increased in size or if you have an hypertrophy of it. So this axis is all about the release of the thyroid hormones. And the thyroid hormone is responsible for sensitizing the tissues to epinephrine. So epinephrine is a type of catecholamines, which we'll see in details when we reviewed at the suprarenal glands. But the effect of sensitizing them will lead to an increase in the process of respiration and the consumption of oxygen, and later an increase in metabolism. And once metabolism increases, heat will be produced as a byproduct, and the body temperature will be maintained at a normal range that we know of about 35 to 36.7. And also, it's also responsible for the growth and development in rather an indirect way. So chemically, so thyroid hormone consists of two hormones. So that's the thyroxine, which we usually just abbreviate is a T4, and another one called 3,5,3 triiodothyronine, which we simply abbreviated as T3. So it's formed by two iodinated tyrosine precursor, and once you combine them, you end up with the two hormone. And in our initial classification, we said some hormones are lipid soluble, and they have the intracellular receptors either located within the cytoplasm or at the nucleus. And one example of this hormone, we said it has to be lipid soluble. An example of it is thyroid hormone. So diagrammatically, that is how it appears. And we can have an abnormality associated with the thyroid gland, which can occur because we either have an excess of it or we have too little of it. One example of it is what we call the hypothyroidism associated with a lower level of thyroid hormone. So iodine is a precursor, and if for some reasons we don't have sufficient amount of iodine in the diet, it will lead into the process of hypothyroidism. And for that reason, the salt is usually iodinated or it's supplemented with iodine in regions where we might have low level of naturally occurring iodine. But with that form of hypothyroidism due to low level of iodine in the diet, the incidences of prevalence are quite low. But in some regions or some highlands where iodine doesn't occur naturally in the environment, that one can be possible. So we have an hormone secreted by the anterior pituitary gland called the thyroid stimulating hormone, and that one will continue to cause the gland to produce thyroid hormone. But since we don't have a precursor, which is iodine, so the gland will increase in size or it will undergo a process called hypertrophy. And the gland become bigger in size, so the lobule increases, and we call that one goiter. So other features include the air become a little bit thin and will be associated with feeling of coldness or cold intolerance because we have low level of circulating of the thyroid hormone. If the level goes too high on the other side, we call that one hyperthyroidism. And it's because of the overactive gland. So for example, a condition called the Crave disease, which will your immunology class will take you in detail. But it's simply we have an immunoglobulins that is mimicking thyroid stimulating hormone and taking the thyroid gland into the overdrive, thus continuing to secrete a lot of T3 and T4. And that will be associated with features like hot flashes or heat intolerance. The body weight will go down because of increase in metabolism. There will be hair loss, and you can have that the eye will be protruded due to the edema at the posterior side of the eye, which we'll call that one the proptosis. We are almost approaching toward the end of this class, but let's have a slight mention on something, on some gland that is located in isolation. So this gland is not so much under direct control of hypothalamus. And this gland function both as an endocrine and as an exocrine gland. So the exocrine gland is associated with the process of digestion. So that is the pancreas. So it increases or secrete an enzyme called the pancreatic amylase, which is used in the process of digestion. We'll see that one when we review about the JT. But within the pancreas, we have small, if you look under the microscope, so we have some small cells that are dispersed around it, and they almost appear like islands if you see it in a microscope. And I hope in your last class when you went to most, you are able to appreciate and look at cells, how they appear through the microscope. So if you look at the pancreas through the microscope, you can see some cells that are distinct and appear like an island. And we call them the islets. So the word, the islets of Langerhans. So the Langerhans was the guy who initially did the histology. And we refer it to the island of that guy. So the islet of Langerhans, which simply means an island. And these cells that appear like an island are of different types, but the significant one are the beta cells, which secrete insulin, and the alpha cells, which secrete glucagon. And they all have an effect in regulating the sugars level in the body. That if the glucose level goes high, it will cause the secretion of insulin from the beta cells, and it will take the sugars level or glucose down. On the other side, if upon after several hours, the glucose levels start to go down in blood, the beta cells will stop secreting insulin, and the alpha cell will take over and secrete glucagon, which will increase the sugar level through other mechanisms. When we review the process of metabolism at the liver as a function of the liver, we'll go into details how this one functions occur, but it was worth mentioning being an endocrine gland. And when you have an abnormality in the beta cells, so for example, we have an autoimmune disorder that has caused the self-destruction of the beta cells, we'll end up with a type of diabetes called type 1, which simply means it's insulin dependent. But in adult, for some reason, sometime the cells will become dormant and they will not be able to secrete enough type of insulin, or the sensitivity of the cells to insulin peripherally will become or will decrease, and we'll end up with a condition called the type 2 diabetes, which we'll see in details in the subsequent sections. So lastly, let's look at the growth hormone. So the growth hormone is secreted from the anterior pituitary gland, and the secretion is usually predominant during the early stages of infancy and childhood, and it's responsible for the physical growth. So the hormone causes growth by inhibiting the uptake of glucose, and in turn increasing the uptake of amino acids. So once you increase the uptake of amino acids into the cells, so amino acids are the precursor for protein synthesis, which we reviewed in the cell biology or in our initial section. So when you increase the process of protein synthesis, so the protein will increase in the body, and depending on the type of protein, that organ will increase in size. And the secretion of growth hormone doesn't occur in a rather continuous fashion, but it occurs in a pulsatile nature, that at some time, during some time of the day, the secretion increases, and in some other time, the secretion goes down. So that pulsatile nature, one of the time that it peaks is during the process of sleep. And you might have heard that the parent says that a child sleeps, and when they sleep, they grow. So that statement is true physiologically, because during the process of sleep, the secretion of growth hormone increases significantly. So that one literally means that when a child sleeps, so their growth will increase. And it's evident for the children that have impaired sleep that their growth become a little bit retarded. So the hormone on its own doesn't act directly on the cells, but it actually causes the secretion of another factor called insulin-like growth factor. So it's not related with insulin in any way, but it's secreted from the liver. And the insulin-like growth factor, specifically type 1, is what is responsible for the proliferation of the chondrocytes. These are the cartilages, and this will lead into the growth of the bone plates, and thus an increase in height will occur. So it also causes a differentiation and proliferation of the muscle cells called the myoblast. And we said initially that it causes the stimulation of the amino acid uptake, and the process of protein synthesis in muscles will occur. What will happen then when you have an excess production of growth hormone? For example, when you have a tumor at the anterior pituitary gland that is causing an excess production of growth hormones, so this will lead into an excess growth. And if it occurs while a person is still young, that is because we mean before the age of 18. We'll call that one gigantism, and a giant will literally be formed. So an example of a giant, I think you are aware of this guy, you call him your giant, call him the Gen Z giant, as Bradley Marongo. So he's an example of a person with gigantism. He simply had an excess growth hormone in his childhood, and for that reason, most of his organs have become in excess compared to ours. So if it occurs when an individual has passed the puberty, we call that one the acromegaly. And the flat bones usually don't have the end plate, and they continue to grow in the presence of excess growth hormone. An example of a flat hormone is the jawbone, and this individual usually have a very protruded or elongated jawbone, as you can appreciate in this image. So up to that point, I request to bring this class into the end, and at the next time tomorrow, we'll continue with calcium synthesis. I don't know